I think the greatest limitation would be the nephrologist trying to get used to echo probe and trying to get the right atrium. So as such, I find not very many nephrologists are comfortable in focus and doing a routine biopsy and things like that. So this will be altogether a different skill, which might be much difficult than getting availability of a C-arm and fluoroscopy. Having said that, you unshared, no? Yeah, I'll share my screen and try to show you some instances where, in spite of fluoroscopy, also sometimes we get into trouble. So, what if you don't even have fluoroscopy? So, you just this is yeah. So this happened few days ago. So this is a right tunnel catheter done with fluoroscopy with C-arm, and I managed to get the guide wire into the IVC. So I was so sure and so confident, rather overconfident. Then I, dilated and put in the dilator, and the catheter is here, and there was good flow on both arterial and venous side. What is the big deal here? Do you find anything amiss here? Except that the catheter is not into the, deep enough to be in the right atrium. So I was going to leave the theater. I thought everything is fine, good flow on either side. But somehow the shape of the lower end, I was, quite uncomfortable. Why is this not going straight? Why is it going that way? Then with, as a last minute thing, I called for a contrast and put in the contrast. You see, anybody else or any other time, people would have walked out thinking that the catheter is in situ, and then I had great difficulty. I mean, once I realized it is in the zygos system, yeah, zygos. Then I was tensed up. Then see, this is not right IJV alone; it is right tunnel catheter. So pulling out the catheter again and repositioning all will be a mess. Then I try to put in the guide wire, and now you see that the guide wire again. The J tip wouldn't go in because this is that barred glide path catheter. Somehow the J tip wouldn't go inside. So I had to put the other side, other end, which was carry to put in the other end. And you see that it was going into the Zigas. So I didn't have the guts to manipulate the guide wire any further. So I pulled out the guide wire and partially pulled out the catheter also. Then luckily I was able to manipulate without a guide wire. The catheter went in and got into position, and you see the contrast right into the right atrium and the thing. So this is in spite of fluoroscopy. So I simply can't imagine doing things without fluoroscopy. And about with all the limitations of echo window for cardiac probe, will he be able to get echo direction of the position of the guide wire or the catheter like this as comfortably as with fluoroscopy? Fluoroscopy, you don't need to have any ingenuity or all you see the screen and you're going to get where you are and what you are. And having said this, Dr. Jaivinesh, are you there?
Yes, sir, I'm there. I'm there.
Yeah, yeah. I think this was the image sent by Jaivinesh. Can you talk about this? Is it a video?
Yes. Can I share my screen, sir? I have a video.
Yeah, quickly, because we have others to
yes.
come.
It is ready, sir.
Have,
it is ready. I'll just finish it in a minute. Yeah.
Yeah, and I have great Vail Aravind there, which is going to show much more scary videos where he has done left-sided catheters without either
I'll just finish off in a minute.
that is for daredevil people. But anyhow, he might be able to give us tips on.
Yes.
Let's see.
Yeah,
This is Dinesh. Yeah.
Yeah, sir. Is it visible, sir?
Yes.
Yeah, so again, this was a case, this was the first time tunnel catheter on the left side. Like the first few steps were fine. You could see the guide wire is well parked in the IVC. But then there was some difficulty while putting in the catheter. Now, regularly, we do not do over the wire insertion of catheter. We pull out the guide wire once the peel away sheath is inserted. But then in this particular case, the catheter was not going in well. And that is when we took the first shot of angio, and this is how it looked. I'll play the video. And this is when we were taken aback. So it was so obvious that there was some false lumen and there was some reconnection happening. So we reinserted the guide wire and we could see there are two tracks. So the one that is going through the normal anatomy and the one that's probably through the false track that was created secondary to the pressure while handling the peel away sheath. Again, this is under fluoro, just like how you mentioned, sir. So I didn't have a stent graft or anything to back it up. So the patient was stable, but so hemodynamically, the patient continued to be stable. So with the balloon that I had, I just created some amount of tamponade. This maybe one balloon size lesser is what was immediately available, and I had to use it. And luckily, the patient continued to remain hemodynamically stable. And this was the last shot after the balloon tamponade for 10 minutes or so. There was still some leak that was persistent, but major blood flow was through the native veins and the patient did not have hemodynamic collapse. So we just put in a femoral tunnel catheter and we came out. So the point is, like Dr. Vandana stressed out beautifully when she began, it's not about the 100 cases that we did successfully, but this one case that almost kind of took a toll. We were so lucky that without a stent backup or anything, we were able to save the patient. For a minute, I thought that's the end of the patient or my interventional nephrology career as well. That was the thought process that was running in the mind without a backup in a corporate setup. Another small point that I would like to stress is that I initially learned it the old school way. When I was in DM training, I didn't have a fluoroscopy. We had ultrasound and C-arm only. When we began, we had minor issues, that angle, creation, tip position, and everything. But then I switched into a setup where I had fluoro, and then I didn't see any of those minor complications. But now we have our DNB programs, our DNB, the new trainers, beginners are starting to do the procedures. We are back to we have come a full circle. Again, the minor complications like kinks, positions, and everything are coming up. So the big question is, how can we assess the expertise of a patient, and we can give a general recommendation to the beginners or the DM trainees and everybody that yes, you can do it without a fluoro guidance. Dr. Manish clearly said that 10 cases can be was taken as a base mark for their experience as far as his particular study is concerned. But the question is that enough? Can we call that somebody will become an expert in firm care within 10 cases and then they can go on to try with a fluoro and anatomical without fluoro and based on anatomical landmarks and ultrasound. So that's one point that's looking. This is just one case, but we came across several. We have seen that under fluoro, we see wires going in so many directions where they are not intended to go. Be it like the case that you showed into the azygos or into collaterals many times where they even appear absolutely normal, like they're aligned with the normal vein as well. So we might not even be able to pick up whether it is in a collateral or something many times as well. So we have found fluoro to be very handful, and right now we have stuck to the policy of continuing with fluoro as far as tunnel catheters incisions, even if it is a right-sided ones. And mainly because we don't do tunnel catheters straight away in a native basis. It's still the common practice is to put on temporary and then switch over. As long as the vein is not virgin, I think it would be a bigger risk to take any day. And one patient we lose, then we might be in trouble. So that's our experience here.
Thank you. Thank you, Jai Ganesh. And the other case which I showed, so the lesson I learned, that was only a few days ago. Even though you have a fluoroscopy and you have a guide wire into the IVC, so once you remove the guide wire, what happens? Your peel away sheath may not go as deep into the right atrium. It will be somewhere in the SVC, especially in a very tall built persons. So then later when you thread in the catheter into the peel away sheath, it may not take the same path as the guide wire. So it may be a good idea to always do it over the guide wire. So let me take some comments from these cases which we showed just now. Then from the faculty and the audience. Then we'll try to go to Dr. Vela Ravind and see, there may be situations where you don't have both. And so what are the precautions he took and the methods we learned from him? Before that, any comments? I'm sure there
And
will
I
be
think I
many
really
more
appreciate the
bad
cases.
experiences. Yes, yes, Vandana.
Now, I was just going to say, I just wanted to tag on to Jay's comment earlier about the training and whether 10 is enough or not. And, I had the great privilege of writing the HVA certification criteria for ASDEN, a long time ago. And we really debated how much time does it really take you to train, because the issue that he pointed out so aptly is not just knowing how to do it, but how to deal with the complications if you get it. So how many is the right number is really critical. And I just wanted to emphasize that point, because he made a great point on that. And thanks for sharing those cases. It's hard to share the cases where things go wrong, but it's very important for our learning process for all of us, so that we don't have that cowboy approach of thinking that, I can do it. And again, I go back to saying, even if you can, should you do it or not? But that was amazing presentations from everyone. And even Manish's presentation, I really enjoyed that. So thank you for inviting.
Can I just very quickly add that to Vanda's comments? So great presentation, Dr. Behra, and it was great, to be able to place catheters at PGI at an elite institute where you can do it under ultrasound in selected patients carefully in a randomized controlled trial. You have a backup if there is something that goes wrong. Once you approve the practice and XYZ in XYZ city in India, in rural India, starts doing it, and you have no backup, that's where the rubber meets the road. So you got to be very, very careful about approving these things. Can you do it? Yes, absolutely. I mean, can we do it blindly? Yes. If we can do blindly, why can't we do it with the ultrasound? Yes, it can be done, but should it be done? That's the question. And then you have to think about what Tushar said is also very important, is if there is a country, I got an application in ISN for a center in a very small country like Tahiti or something, where there was absolutely no interventional nephrologist or nephrologist, even internist trying to do the catheters. Yeah, maybe that's where you can put in an ultrasound and say, okay, yeah, you know what, before the patient dies, at least try the internal dialysis catheter, or maybe even just work with the temporary. So you have to match the and the landmarks that you showed may not be the same for in India, in America, in Africa. They are also going to be different. So it doesn't matter what landmark, and patient to patient, and if they had a previous catheter, everything changes. So you just cannot depend on those. And yes, you have to have that contingency that you can probably do it under ultrasound when there is absolutely no resource, and this is the life-saving measure. I think I'll be okay with that. But in routine, I would not recommend that, at least at this stage, until we become really expert in how to do the ultrasound and develop that technique further. So that is good for a start, but not for the prime time yet. Thank you.
Yes.
So there is a very interesting question in the chat box to Dr. Manish Rathi. Dr. Ramanjit is asking, sir, what is your idea if we put each and every patient IJV non-tunnel catheter and followed after a few days by exchanging it with a tunnel catheter after ensuring all sterile precautions? So he says that why not put all temporary catheters initially and then exchange with a tunnel catheter?
We have done that. Yeah. So I will let others take, but we have done that. If you previously have one which is working, you can exchange it. Nothing wrong with that. But if your intent is to put in a tunnel catheter, then putting a temporary and then subjecting the patient to 2 procedures is also another debate and expense. Thank you.
So can I make 2 or 3 comments quickly?
Patient who is crash landing with end-stage renal failure, then we have to do a temporary catheter, and a few weeks later go on to the permanent catheter through that. Just one more comment. See, basically, I want to find out if you want to do a foot end elevation, it is not possible in the fluoroscopy room. So if you want to have a jugular well distended and then visualized by ultrasound, we need to have a foot end elevation. It will be easier, but that is not possible in ultrasound room. I mean, in fluoroscopy room. So I just want your comment on that. And second thing is a comment about the sterile precautions that are handled by the interventional radiology team. I have seen that the sterile precautions for a perm cat must be very meticulous, but that is not followed in the radiology generally.
Sir, my C-arm is in the theater, and I do it in the theater. And the theater table, you can bring your foot end up, and there is nothing deficient in sterility either. But I don't know whether everybody will have access to theater and C-arm.
For CM, yes, but what about the fluoroscopy? If you want to do it in the cath lab, it is not possible to tilt the cath lab table.
Sir, the current generation of cath labs or the CM tables have all the options of tilting them. In fact, they just act like your cot, wherein you can tilt all the angles. So that issue of
Sir is
tilting them is
actually
not there. Yes, sir.
having in mind the regular X-ray room table and
Yes.
the
Yes.
fluoroscopy. So when I say fluoroscopy, I keep C-arm in mind and theater. But
Yes, yes, sir.
Dr. Bala, sir, can I make few comments,
Yes.
quick comments?
Yes.
So first of all is regarding this ultrasound and echo probe. Actually, it's not difficult because you are not doing a cardiac kind of echo and you are not doing ejection fraction or other things. You just want to know RA and tip in RA. It just take 1 or 2 minutes. Very simple technique. If you start doing, it's not an difficult thing to learn. Unlike your fluoro, you were comparing that fluoro is easier maybe for you, may not be for others. So just want to tell you that ultrasound echo probe is not a difficult thing. It required just 1 or 2 minutes more and you are done. That was point number one. The point number two was that I'm not, please don't take me as that I am saying that you should do catheters without fluoroscopy, even if you have fluoroscopy, available with us. The entire point was to generate data that if you have, because there are a lot of medical legal concerns. I was talking to people that there are a lot of medical legal concerns. People were putting without fluoroscopy and they were scared that somehow if somebody asked, even if it is a successful catheter placement, somebody asked that on what basis you have done it. We have to generate this kind of data even for the so-called standard of care. I think we should generate some kind of data. And the entire purpose of this study was to generate data that keeping all these things in precautions and keeping these things in mind and taking the help of these techniques, you can still do a successful placement of catheter. And third and minor point is in our medical field, and when we do stats, we always talk about NNT, which is number needed to treat. And if you talk one complication in your 1,000 patients, I think you are not justifying even fluoroscopy. You may say, emotionally that even if you have done 100 cases or 200 cases and you land up into one complication, you are not justifying the procedure. It's wrong, actually. Anyone can land into procedure. Even you can land into problems and complications, even with fluoro. So saying that if you have landed complication once in hundreds or 200s or 300s, then you should not say that this procedure is not optimal. I think that we should all keep our minds open, that there are options available. We should all go through those options. If we are well trained in those options, utilize those options. That's all what I want to say. Thank you.
Yeah, great, Manish. I mean,
Can I add something, Bala?
Yes, yes.
So from my side, I agree with what Manish is saying. I think this is a skill that interventionalists need to have. That is placing a catheter without fluoro. There are instances like Tushar said, where you will have to do it without fluoro. And in our case specifically, it's the very obese patient who cannot fit on the table. And we have done these cases at the bedside. So I think it's a good skill. You must have it so that you can use it in that rare patient. Coming to the use of ultrasound, I'm very passionate about it. I'm trying to teach our fellows also the same thing. How to use echo to find the tip of the catheter. We haven't started placing it like that, but it's something that I want to do. But I'm so afraid of medical legal complications, because if I have fluoro, what is the reason I'm going to give that I want to use echo? So that's the second thing. The third thing is about the wire. The wire is very hard to see. It's, for me, I use this posterior approach. to get into the vein. And quite often when I put the micropuncture wire, it will go up into the IJ. So think about it. And the only time I know about this is when the patient starts complaining of pain in the ear. So I know I've done something wrong. So if you go, so to convert from an aldol to a tunnel dialysis catheter, many people do it. And it's something that we also follow, but I tell all my fellows, if you're going to put an aldol, put it low next to the clavicle so that we can convert to a tunnel dialysis catheter later on. That's all I wanted to say.
Yeah, so just to add 2 points, sir. One is that complications definitely happen even in the presence of fluoro. In fact, the one case when I just joined a corporate setup, that case was good enough to scare me that probably that was my last day in interventional nephrology practice. I was doing I was doing a tunnel catheter insertion in a pediatric case. Lupus nephritis, trying to transplant the girl, and I was doing in cath lab with a CTVA surgeon sitting right next to me for backup. In that case, because of a small tear in the vein and the P-level sheath was not good enough, the catheter wouldn't go, and the child was bleeding profusely. We took her to the operation theater, and during just closing the venotomy, patient had developed a pulmonary embolism. So it is not that complications do happen even with fluoro. So what I would like to add is, one thing is, along with fluoro, we also need to have that dye backup, that we need to have the option of injecting the dye, because all said and done, even in fluoroscopy, it's a 2D view. So you can be extravascular, but still your guide wire is going straight. If it's going into the pericardial space also, but in the direction of the IVC, you can still feel that it is straight and it is in the IVC. Unless you give some dye injection, you're not going to realize that you are in the actual vasculature. So that is one point. The second point is that with the use of microconvex probe, we are able to see even up to the superior vena cava. So you can see the internal jugular vein, the brachiocephalic vein, and the superior vena cava up till the right atrium. So yes, the safety of ultrasound guided procedures has definitely increased by the addition of microconvex probe, and in fact there are a lot of guidelines in America and in Europe regarding the utility of microconvex probe for central venous catheter insertion. So that is one thing that has added to the safety of ultrasound guided procedures. But at the end of the day, having a fluoroscopy backup, knowing what to do, and the knowledge of the guiders and everything is needed. So definitely, as Jainivash has endorsed very much, we are not sure that just by doing 10 or 15 cases, they are competent enough to do the procedures. Yes, they are competent enough to insert the catheters in a simple cases, but when they encounter a complication or some complexity, definitely that's not the case. So yeah, so definitely these caveats have to be kept in mind.
Yes.
Dr. J, I wanted to say that, your image that you showed, I don't think you perforated the brachiocephalic. I'm wondering whether it's an axillary left brachiocephalic vein that you've gone into.
Maybe. Thank you.
Very much possible, sir. Yeah.
Yeah, because you won't be sitting here otherwise. You would have told us a bad story. So the fact that it was benign
and most importantly, be aware of persistent left superior vena cava.
Yeah, again, so that again stresses the anatomical variation as well is difficult to pick up without a fluoro. That again endorses the point that at least on left side in a non-native vessel,
superior vena cava still can be on the left side. So we should be aware of all these things.
Yes. Yeah.
And I'd just like to say one last thing before I do have to leave, so I'm going to step away. But I just wanted to say one last thing to respond to all the different comments here, is that even when you're doing everything correctly and you're using all the tools at your disposal, like you all showed, you will get complications. That's just the name of the game. So if whatever you can do to minimize that risk, I personally think that I would do that. So again, it's not a question of whether I can do it. And it's not a question of, obviously additional imaging is very helpful and whatever we can use. But my thing was, if I have some tools at my disposal and if I can make the risk of complications a little bit lower, I'm going to take all the tools I have at my disposal. And so what I'm concerned about is this you know, I feel like technology and our standard of care, we have moved forward. And especially, like, again, I'm talking not about other countries, but in India, the technology is so advanced. Like, the medicines come there faster. Everybody has, like, it's, at least it sounds to me from when I'm listening to my colleagues in India, that they have so much. And so I feel like if you have it, ultimately, you know, going back to the patient perspective and the patient experience. And I feel like if I was to choose, I would want, if you've got fluoroscopy, you've got ultrasound, you've got everything, I want you to use them on me. So why is my patient any different from anything else? So I'm sorry, I'm belaboring the point, but I feel it's great to have all the tools that we can, if we can use them.
Yes, thank you. But again,
And
I have a question for
apologize, I have to
Dr.
leave.
Manish.
yeah, Vale is waiting. Just a minute. Yeah. So this is always good to upskill ourselves and get used to all the tools available, so that you are not pushed to wall when you get a circumstance like that. See, recently I was called to a teaching institution to demonstrate tunnel catheter insertion. So I go there well prepared and all that. I go to their suit and I find that there was no SIAM. I didn't proceed. I said, sorry, I can't demonstrate tunnel catheter without SIAM, and especially, in a live patient. But I feel like, so it is better to upskill yourself with all the tools available. So once in a while, you might be used, all these